very good afternoon to everyone, and my heartfelt thanks to Dr. Sadhna Gupta, our person for the Foxy presidentship, and Dr. Ragini Agarwal, and really my respect to Dr. Shada Jain also to make me a part of this prestigious first conference of NIGF. So I am really thankful from my heart, and I'm going to share with you the extended pyramid of the antenatal care. Now this, as we all know, every year approximately throughout the world, approximately 200 million women get pregnant. And each pregnancy is a risk, as we all know, and there can be an adverse outcome of the mother or maybe of the baby. And therefore, we all know that totally we cannot remove the risk, but we can reduce it through the acceptable, effective antenatal care. Now this is a statistical evaluation that 99% of the maternal mortality calculated in 2015 were from the developing world. And in this developing world, more than one-third is being shared by Nigeria and India. Nigeria sharing 19% and 14% being shared by the India. So we are one country which are taking a lot of mothers losing their life through pregnancy. And the main thing is that the goal of WHO, the SDG 3 goal, says that we have to reduce the maternal mortality to less than 70 per 100,000. And just as we know, antenatal care is just an umbrella term, It is basically describing the medical procedures, care and that are carried out throughout pregnancy. It's a care of women receiving throughout pregnancy and helping her to ensure and as well as assure a healthy pregnancy state, a safe childbirth. The basic objective or the goals are to promote and maintain the physical, mental and social health of the mother and the baby by providing education on medical nutrition, personal hygiene and the birthing process. The other goal can be detect and manage complications. This is very important, where the role of an obstetrician comes is the managing and detecting the complication during pregnancy, which may be either medical, surgical or obstetrical. Any of these, and here with the role of the obstetrician comes, and develop birth preparedness as well as the complication readiness plan if they occur at all, and help promote the mother through the postnatal period. Just in short, the brief history of antenatal care. In the 1800, it was an unstructured part of the antenatal care. It is only at the time of delivery that the pregnant lady used to come in contact with the person who is delivering. And in the 1800, it is basically the process of childbirthing is being conducted by a person who is a lay person or maybe a family member. And therefore, sorry. And coming on to the definition, we all know it is comprehensive health supervision, or it is a planned examination, observation and guidance given to the pregnant woman from the time till she conceives, till labor and even after delivery. So that's how now been the definition. The goals of the antenatal care, as we all know, is to reduce maternal and perinatal mortality, improve physical and mental health, prepare the women for labor, lactation and through risk identification, prevention and management of pregnancy related or concurrent diseases. The health education promotion, through this we can go through the antenatal care. What happens? This goes back. Now what happened was a concept came. It was 1914 that the Williams from the Johns Hopkins Hospital presented a data suggesting that if the prenatal care is taken care of, then we can reduce the infant as well as the maternal mortality. And with this idea, the UK ministry in the year 1929 introduced the traditional pyramid of antenatal care, in which the number of visits were planned only to start from 16 weeks till the end of the pregnancy. Now there are some things which are really lacking in this traditional pyramid, and they are that the number of visits was much more. There were at least 12 to 14 visits. There is monitoring of basic parameters like height, weight, angioedema, BP, system organ, and routine screening of some like hemoglobin is being done. Now, this means that all of the complications that occur are mainly occurring in the third trimester. That was the basic idea. And therefore, the adverse outcome cannot be predicted. That was the thought at that time, that it can be predicted in the first or the second trimester. And with this concept and with the advancement in the medical knowledge and the technology, the possibility of early detection of risk factors and detection of complication between 11 to 13 weeks enabled an effective treatment or prevention of the disease. So this is the concept that came, and it was basically the Professor Nicolaides, who is supposed to be the father of fetal medicine. He developed a new concept which incorporate that the development and should be focused on very early weeks of pregnancy to identify high risk, so that they can be monitored very closely and receive special medical care during whole course of pregnancy. And this is how came the inverted pyramid of antenatal care. Now, this inverted pyramidal care, as we all know, was introduced in 2001. This basically results in early detection of risk, so that the patient can be taken care of according to the risk factor that is there. And if high risk, if the low risk occurs, then the normal antenatal care is being taken care of. Then, so this basically the concept that was added in the inverted pyramid later on in 2013 is that the first trimester triage was added. And this is basically that the patient's estimation, early estimation of a specific complication and risks, and there is an individualized patient and disease specific approach given to the mother who is having high belonging to this. Now, the things which are being done in the high triage is basically screening by mother of maternal history, ultrasound, physical and biochemical markers, and we can detect aneuploidies, preeclampsia, small for gestational age, macrosomia, gestational diabetes, preterm delivery, miscarriages, and fetal structural anomalies. Now, this was even thought that there can be even much more to the inverted pyramid. So what happened is that in 2017, Lucid came with the concept that the problems that occur is not only in the first trimester, but they occur at the time of uteroplacental contact that occurs. So the early root of these diseases is dysfunctional placentation, and thus must be sought in earlier period of pregnancy and deeper subcellular level. So the changes that lead to insufficient implantation should be sought in the pre-implantation period in relation between the embryo and the endometrium. Now, this even extended the inverted pyramid, and pre-pregnancy approach was added to it to optimize maternal comorbidities, weight management, blood pressure and glycemic control, cessation of smoking, spacing this pregnancies, and this may improve the placentation, resulting in a optimal pregnancy outcome. Now, taking this idea, there are 3-floor model that was being developed after this, and this 3-floor model is basically that is based on the concept that the health effect of the women and their offsprings are mediated by epigenetic and genetic pathways, and the lecture in the morning was that to that only. So contributed to the increased risk of developing non-communicable diseases that are passed into the next generation, which forms a vicious circle. So this is how the idea was added to this. The first floor basically incorporates along is the assessment of NCDs in the pre-pregnancy period and optimizing the disease state. The second floor is the inverted pyramid, as usual that was there, and the third which is being added is the postnatal period, where the appropriate management can minimize the long-term harmful effect in both mother and her offspring. So this may be an ideal screening model, meaning thereby to the inverted pyramid, it is basically a basement which is added through NCD evaluation, and a penthouse was added also, so that the disease cannot be continued into the next generation. Coming on to the model, floors. The first floor, the pre-pregnancy evaluation. This basically is the concept of preconceptional care, and the objective is to ensure that a woman enters pregnancy with an optimal state of health, which would be safe for both to herself and to her fetus. And the goals of preconceptional care are basically screening for high risk, monitoring for chronic health disorders, nutrition supplementation and vaccination, lifestyle modification and optimizing of weight, screening and treatment of infections, genetic counseling, prevent unintended pregnancies, prevent fetal infections and the fetal abnormalities, prevent FGR and macrosomia, and lower the risk, the type 2 diabetes and cardiovascular diseases. So these are the strategies that we optimize the thyroid status. Infection that has to be taken care of before pregnancy are torch, screened and treatment, HIV and HSV to be screened and given treatment. Genetic counseling for especially thalassemia and sickle cell anemia. The advice about the diet and exercise. The BMI has to be optimized to 18 to 24.9. The anemia and the smoking and alcohol to be not to be taken. So this is done through the histories, medical, obstetrical, family, drug intake and smoking, and physical examination done to calculate BMI and BP. Investigation that are done is hemoglobin A1C and total cholesterol. So there's a approach which has come. This is called the 7 cardiovascular health, which is being proposed by the American Heart Association, in which individual is categorized into 3: ideal, intermediate and poor. Now there are 14 marks to be given to that, and this is a table which tells the poor, the intermediate and the ideal. So there are all 3 are current BMI, current smoking, physical activity and health diet promotion. Then the medical things are basically the cholesterol, blood pressure and the fasting glucose that has to be maintained before the lady becomes pregnant. So the ideal score people 0 to 4, they are advised to go ahead with the pregnancy. The intermediate ones are being referred to dietitian or the physical trainers, but it is the poor scorer who are being referred to the maternal fetal medicine specialist to optimize comorbidities like anemia, hypertension and diabetes, evaluation of end organ chronic morbidities like conversion to pregnancy safe medication, screen for infection like in varicella and rubella, carriers of inherited genetic disorder. This is very important, should be offered counseling and workup by genetist, including intakes child workup, genetic evaluation for carrier status and pre-implantation genetics to be offered to them. Periconceptional folic acid of course is being given to everyone now. Now coming on to the inverted pyramid and the first trimester triage, the things which are being done in this period is the aneuploidy screening, preeclampsia and SGA screening, screening for preterm labor, screening for diabetes, screening for anomalies. Now coming on to this is just a diagrammatic representation that the aneuploidy anomaly is detected in the first and the second trimester both, the cervical stem length in second trimester and the preeclampsia basically in the first and the second trimester. Now coming on to what are the radiological protocol that is to be done at the 5 to 6 weeks to localize the gestational sac and to rule out ectopic pregnancy. Then changing the drug safer to the pregnancy, and lastly to determine the gestational age, that is very, very important in the earlier part of pregnancy to calculate the risk. From 11 to 13.6 we calculate the NT-NB. Doppler studies are done for uterine artery, tricuspid valve, hepatic artery, ductus venosus and cervical length. These are the things which are being done in the first semester. And aneuploidy screening being done through the 2 tests, that is one is called the conventional screening and the other is the cell free DNA screening. So this is a diagnostic that in the first trimester it is a combined test which is being done. In the second trimester it is the quadruple test. In the first and second trimester combined is a fully integrated or serum integrated or can be sequential or stepwise conventional. Then coming on to the cell-free DNA, a few lines that this is basically the DNA which comes from the apoptotic placental tissue, and this can form a good thing for the diagnosis. Though it was first identified in 1997 as a potential source of prenatal aneuploidy in 1999, and commercially it was used from 2011. This can be done even for aneuploidy even before the ultrasound, and that is from the 9 to 10 weeks it has to be done. And the things which can be done through this is the whole genome sequencing, chromosomal selective or targeted sequencing, the single nucleotide polymorphism. Now the test has got a sensitivity for Down syndrome as 99%, trisomy 18 96, trisomy 13 91, and Turner for to be 90%. Specificity for autosomal trisomies is 99.9%, and false positive rate is only 0.5 to 1%. So, and the result is available within 7 to 10 days. So this is a very good method which can be continuing in the first method. The things which are to be done is the demographic characteristics, do uterine artery pulsatility index, and mean arterial pressure is taken for preeclampsia screening. This is being added to this is the serum biochemical marker like PAP-A and PIGF. Now this combined, the two things can potentially identify subsequent development of preeclampsia before 34 weeks in 90%, 80% between 34 to 37%, and 60% after 37 weeks. And so that we can start, this is basically done so we can start the aspirin in the first trimester. Then SGA, again the same parameters are taken, and it has been identified in 75% of SGA pregnancies can be identified being to be delivered 45% at term, and false positive rate of this for SGA is 10%. Screening for diabetes, I know what are the complications. This is just a list of complications that can occur due to diabetes, and therefore we are supposed to do a logarithm. We can directly calculate the detection rate, which is 60% if we take the maternal age as the indicator, combining it with the serum adiponectin and sex hormone binding globulin, the detection rate becomes 75%. And nowadays, as we know that we have got a 75% glucose challenge test which we can diagnose GDM, and therefore this is a very important thing to have a glycemic control, either diagnosed by GDM or even have a glycemic control can be achieved in the first semester. Cervical length screening, it's usually done in the second trimester, but it is also done in the first semester for recurrent pregnancy failures. In the second trimester, we can do the cervical length and the shape of the cervix, which becomes funneling in the cases of incompetent os. So it is not only the second trimester, it is in the first semester also that the cervical length should be done and the morphometry should be done. And McDonald's stitch can be applied or the progesterone can be given. Then this is just a slide in which one can see that the history indicated cerclage is basically if there is a history of 3 or more preterm births. USG indicated when there are 2 and we find the cervical length less than 25 mm at less than 24 weeks, and emergency cerclage just to take a chance. So these are the type of cerclage just to share. The second trimester preeclampsia prediction is basically done by calculating the SFLT1, which is increased, and the pro-angiogenic factor PIGF, which is decreased. And once this happens, there is the ratio between the SFLT1 and PIGF ratio is elevated at before the onset of preeclampsia, and therefore we can predict and take definitive measures. The structural anomalies which can be definitely diagnosed in the first trimester are body stock anomalies, anencephaly, A lobar hydroencephaly, examphilos, gastroschisis, and megacystosis. There are certain anomalies which are undetectable in the first trimester, but they can be diagnosed in the second or third trimester. And the list is microcephaly, hypoplasia of cerebellum or vermis, hydrocephalus, agenesis of corpus callosum, achondroplasia, echogenic lung lesions, and renal abnormalities. And there are the third type of abnormalities which can be detected in the first trimester along with the biochemistry. They can be suspected, and the vaccination that can be done in the preconception period, we all know, is MMR, and during pregnancy is tetanus, and after pregnancy is HIV. And this is just a list. One must know that we cannot give measles, mumps, rubella, herpes zoster, HPV small smallpox vaccine during antenatal period. Coming on to the postnatal care, this basically includes early detection and management of complication readiness, promoting health and preventing diseases, women-centered educational counseling. And we actually here include the diabetologists, the nephrologists, the endocrinologists, and other branches of the medical. And this is basically to achieve the optimum in the postnatal period, so that the lady does not develop the non-communicable diseases later on in life. So this is again the same. Then we go on to the maternal care, and these are the things which are done for the postnatal targeted maternal care: health promotion, assist the mother and family to develop PNC plan, essential postpartum care and skilled attendant, early detection of danger signs and treatment. Then for HIV, PMTCT, emergency procedure, complication readiness, counseling and service provision, and screening for other conditions like cervical cancer, breast cancer, and STIs. The newborn is care is done also in the postnatal period for the provision of essential care of newborn, counseling on infant and young child feeding, early detection of danger signs and treatment of problem, and immunization of the newborn. That has to be taken care. So coming on to the conclusion, the incorporation of the above mentioned protocol in the prenatal care process helps in the standardization of antenatal care from preconception period into the pregnancy till delivery and through the postnatal period. The structured care will help in substantial reduction in the adverse pregnancy outcome, and thus achieving an optimal perinatal outcome as well. The prenatal screening helps to predict the at-risk mothers and fetus and prevent the problem from occurring by means of prophylactic measures and timely intervention. Nevertheless, in unpreventable condition, a multidisciplinary team-based approach is considered relevant. Then the key points basically are that most fetal chromosomal and structural anomalies can be diagnosed by the end of first trimester. The cell-free DNA is a significant advancement. The risk of some pregnancy complications that become clinically evident only later in pregnancy can be established in the first trimester. The first trimester screening also shows some problem in other pregnancy-related problem like spontaneous preterm birth, which I have already enumerated. And in the end, I would like to say that by this approach, the new approach will adhere to the teaching of Hippocrates, who said that we should learn from the past, research from the present to predict the future, as well as it is in accordance with the pronouncement of Galileo that the language of God is mathematics, and we should measure everything that is measurable and make measurable everything that is not so. So thank you very much for the patient listening, and before I conclude, I would like to invite you all to the holy city of Sangam in the month of December 15, 16, 17 to be a part of the scientific Sangam, a Foxy conference. So this is basically that, and
we invite